This is the simulation-based learning for the management of massive hemoptysis during bronchoscopy. This is developed through the NCH Pulmonary Critical Care Medicine Fellowship Division, as well as the Simulation Learning Center at NCH. The objectives of this project are to understand the background of iatrogenic airway bleeding, to provide an introduction to the Hemoptysis Simulation Project, to introduce an airway bleeding algorithm, as well as a learner checklist, and to review airway management and procedural techniques in bronchoscopy-related massive hemoptysis. The difference between massive and non-massive hemoptysis has changed and continues to be a fluent definition. Massive hemoptysis can be understood as the expectoration of a large amount of blood and a rapid rate of bleeding. Volumes anywhere between 100 to 1,000 mLs of blood have been described to indicate massive hemoptysis, but there is no specific volume that is universally accepted. A large volume of blood alone is not necessarily definitive of massive hemoptysis, but rather the amount of blood to cause significant life-threatening injury to the patient, either through functional airway obstruction, i.e. asphyxia in the airways, or through shock by exsanguination due to blood loss. The mortality rate from untreated massive hemoptysis is more than 50%. Interestingly, the airways themselves can hold only 150 milliliters of fluid volume. Prompt recognition of severe hemoptysis and identification of its causes are mandatory to initiate adequate treatment and to avoid fatal complications. The source of hemoptysis can come from two different types of circulation. So the blood supply to the lungs is derived from the pulmonary arteries as well as the bronchial arteries. Pulmonary artery circulation is a low-pressure system that supplies most of the lung parenchyma, and most episodes of hemoptysis that are non-life-threatening originate from here, and this blood flow arises from the right ventricle. Conversely, the bronchial artery circulation is a high-pressure system that comes from systemic circulation and mostly supplies the endobronchial tree. Bronchial artery circulation is 2% of the total vascular supply to the lungs, and bleeding from bronchial arteries is most likely the cause of life-threatening hemoptysis in up to 90% of cases. Non-resolving life-threatening hemoptysis often requires arterial embolization, particularly in the bronchial circulation, and less often in the pulmonary circulation. This is a diagram demonstrating both the sources of hemoptysis from pulmonary and bronchial artery circulation, and in the bottom right-hand picture, you can see that there's 4 types of vascular anatomy that are dependent on an individual's anatomy. So bleeding is not one and the same for each patient. In one study of over 20,000 bronchoscopies, a retrospective analysis showed that the most common complication was hemorrhaging. Severe complications and mortality rates in bronchoscopies are actually quite low. However, the most common complication and most frequent severe complication is associated with bleeding. Bleeding of any severity can happen in approximately 1/3 of patients. Usually this is mild and easily controlled. This is bleeding such as trauma, scope trauma on the walls, suction trauma, things like this that don't necessarily need any type of treatment. Overall bleeding rate is higher in biopsies from the left upper lobe and from the bronchus intermedius, and severe bleeding rates were highest from the bronchus intermedius. This is likely due to the anatomy of vasculature surrounding the bronchus intermedius. The overall bleeding rate, severe bleeding rate, is higher when only one biopsy is performed compared to with more than one, and this is likely speculated because if you biopsy one area and it bleeds a lot, you're less likely to go on to do further biopsies in that same patient. There are also higher severe complication rates in inpatients compared to those that are outpatient bronchoscopies, which makes sense that these are emergent cases and probably in some cases often performed because the patient is already having hemoptysis. Most bleeding that occurs during a bronchoscopy is controllable, but massive hemorrhaging can be life-threatening. Hemorrhage can obstruct the airway within a very short time, and topical and intravenous hemostatic agents are often used as first-line approach, followed by urgent bronchial artery embolization, and emergency surgery is sometimes required. In one study, the average fatality rate in patients that were found to have massive bleeding in bronchoscopy was up to 10%, with mortality and bleeding associated in patients that have older age, tracheal bleeding, and higher volume blood loss. The management of hemoptysis in bronchoscopy focuses around the early control of the airway, immediate isolation of the hemorrhage, and limiting the spread of the hemorrhage. A coordinated team response is essential to guarantee the best chances of patient survival. Our simulation was developed because massive hemoptysis during bronchoscopy is considered a high acuity, low occurrence event or a halo event. This is a situation that requires early recognition, understanding, and familiarity with a systematic approach and procedural skills. Because this is an infrequent event, however, very high risk, it is challenging for learners to attain proficiency in this essential skill. Existing research has shown that simulation-based learning can effectively enhance management skills of trainees dealing with hemoptysis. There are pilot studies that have been conducted at Northwestern University and the University of Colorado's pulmonary critical care medicine programs that have successfully implemented similar simulation-based models for massive hemoptysis, and they've reported that trainees have significant improvements in competence and performance when managing massive hemoptysis in a bronchoscopy. In our study, we want to replicate these simulations, but also adapt the simulation-based assessments for not just our fellows, but also for our ancillary staff, including endoscopy nurses and technicians that are a vital part of our cases. We have done this by not only creating a simple algorithm to understand the basics of how to manage hemoptysis in the bronchoscopy suite, but also a tailored checklist for the individual roles involved in this process. So we have a high fidelity 3D printed airway model that has been designed to selectively replicate bleeding from specific segmental airways. Learners will have to locate the bleeding and follow a pre-established management algorithm of procedural skills, clinical decision-making, leadership, and communication. After which, learners and participants will be given the opportunity to receive feedback through debriefing and reviewing the checklist, and have opportunities to repeat the simulation in some circumstances. So to introduce the algorithm for massive hemoptysis through NCH, this is to be used in the bronchoscopy suite in a patient that has undergone some sort of bronchoscopy or even during the bronchoscopy and hemoptysis is recognized. So the site of the bleeding should be localized, verbalized, and tamponaded with the scope if possible. From there, ice saline should be administered in 20 to 50 cc aliquots and can be repeated. At this point, there is a variation here to consider APC or argon plasma coagulation if there's a visible bleeding vessel or if you happen to be working on a central airway tumor that was bleeding. The second intervention from ice saline is to move to topical epinephrine. Now, oftentimes we use ice saline and epinephrine in alternating doses, which would also be acceptable. TXA is also an agent that would be acceptable to use if and when available. Next, furthering the process of tamponade, a Fogarty balloon can be used, and subsequent bronchial blocker if needed. If the patient continues to decompensate or hemostasis is not achieved, selective main stem intubation can be coordinated. The patient can be placed with a bad lung down, and the ICU and or IR should be consulted at this point. So again, to run through, you're isolating your bleeding segment and communicating that to the room, applying saline and epinephrine to the bleeding segment, using tamponade devices such as Fogarty's and blockers to, again, isolate and achieve hemostasis. If the algorithm continues and the patient keeps bleeding without an achievement of hemostasis, placing the bleeding lung down and referring to IR and or ICU will be the next step. This is the checklist that will be used in the massive hemoptysis management scenario for the bronchoscopist role. And this really is a more detailed outline of the algorithm. And when you're performing the simulation, a recorder will be watching and evaluating the learner to assess how they address each of these aspects derived from the algorithm. Here is the checklist for the support staff role, i.e. the technician or the RN in the room. And one focus from the algorithm that we had is the bronchial blocker, which is, again, a part of the algorithm that is not often used and would typically only be used in this massive bleeding scenario. And so we focused on this since it is a critical skill with a low occurrence rate. So to review this endobronchial blocker insertion, this is an example of the endobronchial blocker that we have available in endoscopy. It comes with not only the blocker that you can see, but also a connection, an ET tube connector, which has ports for both the connecting to the ET tube, the blocker itself, the bronchoscope, as well as a port to connect to for anesthesia, to connect to the ventilator circuit. You can see in the diagram on the right that the blocker is placed through the ET tube. We'll go into more detail on that in the next slide. Here you can see a more detailed view of what the blocker looks like. So typically you will attach the blocker to the bronchoscope inside that 4-port airway prior to attaching it to the ET tube. So you will put your scope into that 4-port piece, as well as put your blocker into the appropriate port before you attach it to the ET tube. And you'll use the snare, which is controlled at the end of the blocker, to tighten to the end of the bronchoscope. Once you've completed that, you will then put the 4-port connector attached to the ET tube with the bronchoscope and snared blocker already positioned inside. Then you can advance your scope, and the blocker, which is now snared to your scope, will follow alongside until you reach that bleeding segment. Once you're there, at the end of the bronchial blocker, you release the snare from the scope, and it can move independently under direct visualization of your bronchoscope. Once you advance your endobronchial blocker, you then have a port where you can insert air into the balloon, creating hemostasis and tamponade. This is with a one-way valve that will hold that amount of air that you have entered into the balloon. You can then tighten the endobronchial blocker at the top of the 4-port system attached to your ET tube, and you tighten it, and you make note of what length the bronchial blocker is, so that if you're moving the patient, for example, to an IR suite or to the ICU, you know the depth at which that endobronchial blocker is placed. Here we also have visualization where you can see, for example, in image D, there's a rigid bronchoscope that's used, and you can see there's a tool, probably some type of balloon or blocker that's coming out the tip, as well as a flexible bronchoscope. You also have in image B a dual chamber or dual lumen ET tube that you can manipulate with mainstem airway tamponade as well, selective mainstem airway tamponade. And then again, in C, you have an image of your endobronchial blocker coming out of your ET tube, and then in A, you have a selective mainstem intubation. These are the references for this presentation. Thank you very much for your attention.